hypoxia, insufficient oxygen at high altitudes, a smoke or fumes from a fire or contaminated air conditioning, a gastrointestinal issues, such as food poisoning or allergies, a medications. Some medications can cause hypoglycemia, which can lead to incapacitation, alcohol or drugs, a neurological problems, such as stroke or brain tumor, a heart attack, can cause death, the most extreme form of incapacitation. Loss of judgment or skills, not responding to stimuli, making illogical decisions, loss of consciousness, seizures, severe pain and paralysis. Evaluating literature on the frequency of in-flight incapacitations is hindered by the fact that a comparison of the results of studies is complicated by inconsistency, fatal accidents and non-uniformity of the definition of incapacitation. It might be any change in ability to function appropriately, a medical event that resulted, or would have had the propensity to result, in an inability to act as flight crew for at least 10 minutes, or a partial incapacitation associated with symptoms that resulted in a reduction of function or distraction from the flight crew task. Moreover, it might be only in flight or both in and off duty. It can be any incapacitation or only cardiac incapacitation, and it might be caused by either a disease or by external causes. In-flight incapacitation as a consequence of medical problems is a rare event occurring up to 0.45 times per 106 flight hours. There are no reliable data on partial incapacitation because it is not systematically reported. According to a worldwide survey among commercial air transport pilots that was carried out in 1991, the most frequent causes of incapacitation were gastrointestinal, 58.4%, earache due to a blocked ear, 13.9%, and faintness or general weakness, 8.5%. The most common phases of flight where incapacitations occurred were en route, 42.1%, followed by climb, 18.4%, descent, 17.3%, and on the ramp, 11.4%. Safety of flight was felt to be potentially affected in 45% of cases and definitely affected in 3% of cases. Of those reporting that safety of flight had been affected, 43% stated the incapacitation event placed the remaining aircrew under maximum workload. Similarly, other studies looked at in-flight incapacitation rates with various participant groups. This review article reports that overall, the main medical events affecting pilots were found to be myocardial infarctions, cardiac arrhythmias, and epileptic seizures, yet data stems from multiple sources that are broader than simply in-flight medical events. When looking at pilots whose careers have been ended due to medical events in the UK, for example, about half of pilots had psychiatric problems, while the other half struggled with cardiovascular or respiratory problems, or diabetes. There is an increased risk of pilot incapacitation with age, but not all causes of medical incapacitation are age-related. 50 to 70% of the medical incapacitations are caused by problems such as acute gastroenteritis, headache, and ear/sinus conditions which are not age-related. The medical conditions that are age-dependent are caused by cardiovascular, neurological, or psychiatric conditions. These include sudden death, coronary artery disease, cardiac arrhythmias, pulmonary embolism, stroke, syncope, late-onset seizures, and acute psychosis, and can result in sudden and complete incapacitation. In-flight incapacitation as a consequence of medical problems is a rare event occurring up to 0.45 times per 10 million flight hours. There are no reliable data on partial incapacitation because it is not systematically reported. There is an increased risk of pilot incapacitation with age, although not all causes of medical incapacitation are age-related. Nevertheless, Prevention of incapacitation by periodical medical screening is important to minimize incapacitation risk, and this should include screening on psychological issues. There is not a specific measurement methods that allows reliable detection of all types of incapacitation. A combination of techniques will have to be used to measure vital signs and to monitor pilot activity. Self-identification of imminent incapacitation is also important, and pilots may have to be educated to help recognizing symptoms of imminent incapacitation. Data protection rules must be considered, and robust arrangements must be in place to assure confidentiality. The use of some sort of dead man switch, similar to what is used in trains, may be considered. Fatigue is usually not seen as a type of incapacitation and is addressed separately in regulation and operational procedures. It is critical that while the pilot flying is impaired or incapacitated, the aircraft's flight parameters are kept in a safe envelope. This means that at least basic autopilot functionality must be provided at any time, even in the case of system failures, and immediate actions must be performed automatically.